Welcome to Horizon Medical Education Podcast, concise, evidence-based audio lessons for clinicians worldwide. For supporting notes, accreditation, certificates, and access to all our free courses, visit our platform at www.horizonmedicaleducation.com. And just as a reminder, this podcast is intended for medical professionals and for educational purposes only. It does not replace clinical judgment or local guidelines. Episode 2, Chronic Kidney Disease, Part 2. In this episode, we'll be focusing on the prevention and management of chronic kidney disease.
I'm Fran.
And I'm Minnie.
And please do give us your feedback on this module.
So today's tip is identifying risk factors and early intervention prevents further renal function loss.
That's so true, isn't it, Minnie? So we discussed the definition of chronic kidney disease, or CKD, in part 1. We thought now we would focus a bit more on prevention and management. And the general principles of CKD management is to, 1, identify and treat the underlying disease, because as we found in part 1, it isn't always a problem with the kidneys, is it? It might be another disease that is impacting upon the kidneys. Number 2, attempt to prevent further renal damage. 3, look for reversible factors which are causing failure. 4, attempt to limit the adverse effect of loss of renal functions and to treat complications. And 5, to institute RRT, which is renal replacement therapy, which includes dialysis or transplantation as needed.
Yeah, so this is a really massive topic, isn't it, Fran? So we're just going to go through the main bones of the management and the things that you need to be aware of, but it's by no means exhaustive. So we'll start first of all by talking about the management of chronic kidney disease in low and middle income countries, as there are obviously many challenges to delivering CKD care in these countries. This may be because of reduced access to healthcare and also a scarcity of the kidney care workforce. So this includes nephrologists, specialist renal nurses, specialist renal dietitians and social workers. Because of this, it makes early CKD detection and prevention strategies really vital for the patient. And so that should form the sort of main basis of management for chronic kidney disease. And Anaemia et al. Have produced a very useful and pragmatic article called Current Management Strategies of Chronic Kidney Disease in Resource-Limited Countries. And we have put this in the references at the end of the transcript. So do click on that and read it for yourselves if you're interested. Treating advanced CKD with dialysis and renal transplantation, as you mentioned, Fran, this is hugely costly, both in terms of health expenditure for a country and worsening poverty for the individual. So the mortality rate remains very high in individuals with kidney failure.
It's true, isn't it? And what is driving this rising CKD prevalence? Well, it's due to a significant increase in chronic non-communicable diseases that we're seeing in lots of countries. So that's hypertension, type 2 diabetes, and obesity, but also their interplay with infectious diseases that are more common in these low and middle income countries, such as HIV, malaria, and schistosomiasis. Now, some of these risks are preventable and treatable. So, we must be looking at those first of all. But equally, there are other factors at play. So there are some non-modifiable risks. So, for example, there is a genetic predisposition to CKD if you have the apolipoprotein A1, which is a renal risk variant commonly found in West Africa.
Okay, so let's first of all, Fran, look at prevention. CKD prevention includes primary prevention, so this is to prevent the occurrence of CKD risk factors. Secondary prevention, and this is looking at screening to achieve early detection of CKD in the at-risk groups. And then tertiary prevention, so this is aimed at slowing down or preventing CKD progression to kidney failure.
So primary prevention, that's That's things that all of us should be thinking about in our lifestyle, isn't it, Minnie? So, we've talked about it in lots of modules. So it's things like reducing your salt intake, having a healthy diet, preventing hypertension and obesity, which is really increasing worldwide. And all of us, increasing our physical activity is really important for our health.
Absolutely. And then the secondary prevention, Fran, this is looking at screening programs. So you're looking at the risks, screening people's blood pressure, screening them for diabetes, and then also using biochemical markers like the albuminuria and the EGFR, which we discussed in detail in part 1. You can also use days like World Kidney Day that we saw last week to raise awareness in the community, or target that as a day to screen your population for risk of CKD.
I think that's such a good idea, isn't it, Minnie? And there are more and more world days for all sorts of conditions. And, we should be using them to encourage our communities to come forward for screening. I think that's really helpful.
Yeah, it's a good time to educate people about it too.
It's really good, and education is so important. Yeah. And then finally, Minnie, you mentioned tertiary prevention. So that's in the people who already have these diseases. So, if they're hypertensives, you need to be controlling their blood pressure. If they're diabetics, you need to be managing their blood glucose. Equally, if they have high cholesterol, you need to be controlling their cholesterol levels with dyslipidemia treatment.
So as we know, many low middle income countries, Fran, have learnt to manage communicable and chronic infectious diseases really well. But now there's this dual burden of communicable and non-communicable disease. So if you integrate the care for detection and treatment and monitoring of these conditions, it just makes enormous sense, and it helps reduce workload and reduce workforce requirements, and will generally improve patient outcomes and is cost effective to a country, as was seen in Thailand. So in Thailand they did a study called The Effectiveness of Integrated Care on Delaying Progression of Stage 3 to 4 CKD in Rural Communities, otherwise known as the ESCORT study. And what they found here was that this integrated care approach was associated with a delay in the CKD progression when compared to usual care. So this really suggests this is a practical and effective model, so you can manage more than one thing at a time.
It just makes so much sense, doesn't it? And, we talk in primary care about the holistic approach and, looking at the patient as an individual, not as a disease. And, I think this just really reinforces that, doesn't it?
Absolutely, yeah. So we've included in the transcript an infographic which just goes through the primary, secondary and tertiary prevention and the things to look out for. And it's a bit of a flow chart, so you can work your way through that. It's quite a useful way of remembering things.
Yeah, it's really helpful. Thank you, Minnie. So if we move on from sort of prevention to looking at specific interventions, so what are we going to do to help manage these patients? Well, the first thing we're going to talk about is hypertension, because we've mentioned that as being one of the underlying causes. So it's a major cause of CKD, and it has a high prevalence worldwide and is increasing in low middle income countries. So, raise awareness in your communities, look for it, treat it, and then when you're treating it, you need to really control the blood pressure properly. So for most patients who have CKD, you're looking to get their blood pressure at 140 over 90 millimeters of mercury in clinic. So if you have some form of home monitoring available, you actually have a lower target, Minnie, because however relaxed you are when you see your doctor, actually your blood pressure isn't, and it always goes up a bit. So your home target would be 135 over 85. So it's just that little bit lower. However, if your patient has diabetes, or you have an ACR, so this is your albumin creatinine ratio of more than 70 milligrams per millimole, or a PCR, so this is your protein creatinine ratio, more than 100 milligrams per millimole, your target is much tighter. It's actually 130 over 80 in clinic. So again, you'd be looking to take 5 off with home readings.
Okay. So for treatment of blood pressure, follow your local guidelines for which antihypertensives you should be using, and take into account the advice given below for proteinuria. Recently, there was a large multi-center study which has shown that in Black patients in sub-Saharan Africa, amlodipine plus either hydrochlorothiazide or perindopril is more effective than perindopril plus hydrochlorothiazide at lowering blood pressure. So perindopril is an ACE inhibitor. And this was a study that was printed in the New England Journal of Medicine in 2019.
So this is interesting, isn't it? Because we've been always taught that ACE inhibitors don't work so well in Afro-Caribbean patients. So they're not first-line treatment, whereas in young white patients, they are first-line treatment in CKD and hypertension. Yeah. But if you start an ACE inhibitor or an ARB, which would be your alternative, although they are more expensive. So in these patients with CKD, you will have been measuring their creatinine and their eGFR before you start therapy. Mm-hmm. And it's really important with ACE inhibitors or ARBs that you repeat these measurements 3 weeks after starting them. And you might see a small rise in creatinine, which is less than 30%, or a small fall in the eGFR, which is less than 25%. And that's normal, and it's due to the reduction in the filtration pressure in the glomerulus. But if it's more than that, then you need to be looking for other causes, such as other medicines or volume depletion. So that's a loss of fluid. And then only stop or reduce the ACE inhibitor or the ARB as a last resort, because we know these are very good blood pressure tablets and they're very good for protecting your kidneys.
That's interesting. That's really useful advice, actually. So the other thing to note is for monitoring, you will also be measuring the patient's potassium levels. And if the potassium rises above 6 millimoles per litre and other drugs known to promote hyperkalemia, so this is high potassium, that if they have been stopped, then the ACE inhibitor or ARB should also be withdrawn.
And if hyperkalemia is a persistent problem, then we do need to be looking at diet, and advice on low potassium diet would be helpful. Now, the only things that I know off the top of my head, I don't know if these are the ones you remember as well, Minnie, are bananas. Tomatoes, and dark chocolate. And interestingly, yesterday I spoke to a patient whose potassium was slightly high on his medication, and he confessed to eating 2 bananas a day. So, that was an easy win for me, just to get him to cut that down.
Next, we'll look briefly at the management of proteinuria. So if your patient has diabetes and an ACR, that's your albumin creatinine ratio of A2 or A3, you'll remember from looking at the nice graph that Fran showed us in part 1, or if they have hypertension and an ACR of A3, or they have an ACR of greater than 70 milligrams per millimole, irrespective of cause, then you should be offering your patients a low-cost ACE inhibitor or an ARB.
And then moving on to cardiovascular risk. So we talked, didn't we, in part 1, Minnie, about how having chronic kidney disease increases your risk of cardiovascular disease and death from cardiovascular illnesses. And interestingly, so previously we've talked about Q risk. I think it was in our module on hypertension, if I'm correct. And this is a scoring system to see if somebody is at high risk of having a stroke or heart attack in the next 10 years. And it takes into account lots of factors such as age, poverty, blood pressure, cholesterol, and the like. And you don't use it if somebody's already at risk. So if they have diabetes or they have heart disease already, you no longer use it as a scoring system. Okay. And interestingly for me, so I didn't know this, that they say that actually by the time your patient has CKD at a level of G3 to 5 or albuminuria, they're already at significant risk of CVD. So you shouldn't be using Q risk on them. You should automatically be offering them a statin as primary prevention. So in the UK at the moment, we'd be using atorvastatin 20 milligrams, but follow your local guidance. And this is really interesting because yesterday I was doing a tutorial with my GP trainee, and luckily for me, it was on CKD. So I suddenly sounded really quite knowledgeable, really. But this was the thing that she introduced me to, because we were discussing a patient. So it was great. We were discussing a patient who we'd found to have CKD, and we were talking about the management, and she was unsure of what to do. So I got her to do some research. And in fact, I hadn't realized this. And I think maybe looking at it, I haven't been offering a statin enough to some of my patients with CKD. So I'm certainly going to change my management from now on.
Oh, that's really useful. So another of the causes of CKD, as we know, is diabetes mellitus. So we'll have a look at the management of that in conjunction with CKD. Worldwide, diabetes is the leading cause of CKD, especially in high-income countries, because it's driven by the high prevalence of obesity. But data from the International Diabetes Foundation estimates that in 2019, the global prevalence of diabetes to be 9.3%. So that is actually 463 million people.
Insane.
I know, and they're projecting this is going to rise to 10.9% of the world's population. So that will be 700 million people by 2045. So this is a massive 51% global increase.
It's insane. And, you know, the fact that a lot of the driver is by obesity, that just feels so preventable, doesn't it?
Yeah, it does. I mean, interestingly, the rise is projected to be much higher in quite a few parts of the world. So in Africa, it's projected to rise by 143%, the Middle East and North Africa by 96%, and Southeast Asia by 74%, compared to Europe, where it's expected to rise by about 15%, and North America 33%. I mean, these countries already have a very high burden of diabetes.
I wonder, Minnie, and I don't know if the article said this, how much of that rise is due to, changes in diet and lifestyle, which we know contribute to non-communicable diseases, and how much is just in better detection, because we know in parts of the world that people who have high blood pressure or diabetes just aren't being diagnosed and treated. So, I wonder if part of the increase would just be that as well.
Quite possibly. The article didn't go into any more details than that, really, but that's a really interesting question. So managing diabetes, the standard of care includes targeting an HbA1c of about 7% to delay or prevent the microvascular complications. And these are the ones that particularly affect your kidneys. And you need to adjust doses or discontinue oral agents such as metformin if the EGFR is less than 30 mils per minute per 1.73 meters squared, or 30%, as you remember we discussed in the last module.
Oh, so much easier. Yeah, much easier.
Yeah, so you may need to discontinue this treatment for the diabetes if it is affecting the kidneys. So there are newer agents such as SGLT2 inhibitors. What does that stand for, Fran?
So these are sodium glucose co-transporter 2 inhibitors, and they're a new group of oral medications for treating type 2 diabetes, like you just mentioned, and they work by helping the kidneys to lower blood glucose levels, so you excrete this excess glucose through the kidneys.
Okay, and these have shown significant benefits in renal outcomes, so in patients with chronic kidney disease, and better cardiovascular outcomes and mortality in general. So that's great, but their cost and availability may be an issue in many parts of the world.
And we mustn't forget, must we, Minnie, that, lifestyle measures, so that's weight reduction, exercise, reducing alcohol, stopping smoking, these should all be reinforced to these patients. So
next, we'll talk about the management of glomerular disease, including HIV and other infections. The glomerular diseases are common in many low-middle income countries, and this may contribute significantly to the burden of CKD from these areas. The diagnosis of glomerulonephritis, or GN, is often limited by the lack of diagnostic tools such as the assessment of serum autoantibodies, 24-hour protein estimation, and also the availability of a kidney biopsy. The treatment of glomerulonephritis is cause specific, so making the correct diagnosis is actually really important to allow you to treat with the appropriate immunotherapy. However, at the same time, the use of an antiproteinuric agent, for example, an ACE inhibitor or an ARB, blood pressure control, treatment with diuretics, and the use of anti-lipid agents and reduction in salt intake may be useful, as we've already discussed, really. In Africa, where HIV is common and actually may present with glomerular disease, or where treatment with tenofovir may actually worsen kidney function, it's really important that all HIV positive patients are actually started on a kidney-friendly antiretroviral therapy, or ART. So these have been shown to reduce progression of disease and mortality due to the CKD. So although some studies have shown some benefits when using corticosteroids in HIV patients with glomerular disease, further studies are really needed to assess the value of other immunotherapies in this group of patients.
And also it's important, isn't it, Minnie, to consider and treat other infectious conditions such as hepatitis B, C, schistosomiasis, syphilis, etc., that can also be associated with CKD.
Absolutely. Gosh, there's so much intertwining between conditions, isn't there?
Yeah, and we were talking about it earlier, weren't we? How certainly in the UK, specialists have become so specialised that they only look at one tiny bit of the body, but health isn't like that, and so that's where primary care is so invaluable to patients, isn't it? Because we see all the conditions and the overlapping nature of them.
Absolutely.
So the next thing that we thought we would talk about with you is avoiding nephrotoxins and adjusting drug doses. So we mentioned nephrotoxins in part 1. So there are lots of medicines that are bad for your kidneys, and traditional and herbal remedies fall into this, and they are often used worldwide for the treatment of acute infections, for example malaria, and for many chronic health disorders. And there are lots of reasons for this, and that might include cultural reasons, it might include lack of availability and the cost of healthcare and medicines. But the trouble is they are not regulated, and herbal remedies have been associated with acute or chronic kidney damage. And it's really important to raise awareness in your communities on the impact of unregulated herbal remedies on kidney disease. Alongside that as well, check your patient's prescriptions, because it may be that they're using some medicines that they shouldn't be. So interestingly, I was phoned by the laboratory with someone with acute kidney injury recently, and she wasn't my patient, I hasten to add. And accidentally, she had been put on 2 different non-steroidal anti-inflammatories. And I think probably somebody had said, well, look, let's try this one instead. But she'd misinterpreted, and they'd both ended up being issued. So she was on 2 of those, plus a really strong diuretic for her blood pressure. And, just by cutting her medicines down and looking again at her pain relief, because obviously she needed some pain relief, her kidneys bounced back, and are now very happy again. Check your patient's prescriptions, because errors happen really easily, and ask about what they're buying over the counter. So, non-steroidal anti-inflammatory drugs are a real one that people buy easily over the counter. They're very good drugs, they're great for pain, but they can be bad for your kidneys. And if you've got a patient who's at high risk for CKD and stomach ulcers, as an aside, you need to suggest they don't take them. Yeah,
absolutely. You should always consult your local drug formularies so that you can adjust doses for drugs for the level of renal function of your patients. A good example for this would be metformin that we've just talked about for diabetes, where you might either need to reduce the dose or change the medication to something else.
So moving on, we spoke about this really briefly, didn't we, just now, looking at nutritional and dietary management. So guidance generally say that all individuals with CKD should receive dietary advice. And I think realistically, it's probably only those who end up seeing a nephrologist who would get that much more specialist dietary advice. But as I mentioned with my patient with bananas, you might want to be giving them advice on potassium. All of them we should be, well, everyone really, we should be telling to reduce their salt intake, because, I think probably worldwide people's salt intake is too high. But, we need to be practical, and we need to be sensible about this, and we need to take into account, what is the diet in your local community. So you need to think about the local conditions. So if where you are is very hot, you need to reevaluate the fluid advice that you'd give someone. So in the UK, where it's really not very hot and quite rainy, you might fluid restrict to a different level to if you're living somewhere where it's 30 degrees every day. You need to, think about literacy levels. If you're giving them advice on what to buy in the shops, can they read how much salt something has on the packet? Just be mindful of that. And I think one of the things that I find really interesting is being aware, even in the UK, that lots of people really can't read very well. And you just need to be very sensitive when you ask about it, and how you ask, because people are often quite embarrassed about it. And then sort of cultural practices as well. So you just, be pragmatic, think about your community and what sort of advice you're you're going to give. And then, like I'm saying, you're going to think about how much fluid somebody should be taking, reducing your salt, looking at their phosphate, potassium, and in later stages, looking at protein intake as well.
Yeah. Okay, and we'll now take a moment just to look at the treatment of complications of CKD, which include looking at fluid overload, anaemia, and mineral bone disease. So we'll start with talking about fluid overload. Disorders of sodium handling in the kidney become more prominent as CKD stages advance, and this usually results in a patient becoming fluid overloaded. Now, this fluid overload contributes significantly to the cardiovascular morbidity, which we've talked about, and this results in hypertension, that's the high blood pressure, left ventricular hypertrophy, and mortality in CKD. So the management, there are a few strategies, one of which we've just briefly touched on, which includes restriction of fluid intake, reduction in dietary salt intake, and the use of diuretics. Now, you can get more details on what and how to do this in a document that we've put as a separate PDF by the Kaideco group.
Brilliant. So moving on to your second complication, Minnie, anemia. So the prevalence of anemia increases as the EGFR declines, and this is especially true from stage G3B onwards. And that's mostly owing to the failure of the kidneys to produce erythropoietin, as well as some iron deficiency, which is some true iron deficiency, so you really are deficient in the body, and sort of relative, and that's due to the fluid overloading. The treatment involves replacement of the iron and some erythropoiesis stimulating agents, or ESA. So that's normally EPO, and that can be given by injection. The management of CKD-related anemia, there are guidelines available, and these include the target that you're aiming for your hemoglobin and other indices of anemia to monitor response. So that might be your ferritin level, for example. Okay. Now, in the UK, we've mentioned it before, we have something called NICE, which produce our guidelines, and they suggest that patients with stages G3B, G4, G5, and a hemoglobin of less than or equal to 11 grams per deciliter are referred for IV iron and subcutaneous EPO when other causes of anemia have been excluded. So, I mean, this is the complicating factor, isn't it? That you do have to make sure that they don't have, a intestinal malignancy that might be making them anemic as well. And they suggest that once somebody has had the IV iron, then you can switch to oral iron to maintain the ferritin levels at above 200 micrograms per litre, which is pretty high ferritin level, actually. That's above a normal range. Now, in low and middle income countries, you probably need a little bit more research to look at CKD related anemia, because there might be other modifying and other contributory factors other than just an EPO or an iron deficiency, such as parasitosis, hemoglobinopathies, and nutritional deficiencies, as well as I've already mentioned, other illnesses that may be at play. Yeah,
it's a lot to consider, really, isn't there, Fran?
Yeah, well, and I guess what you can always do if you're not sure is replace with EPO, and if it doesn't make a difference, well, then there might be something else going on. Sometimes a trial of treatment is your hypothesis, isn't it? And that gives you the diagnosis once it works or doesn't work.
So the next complication that we're going to discuss is the mineral bone disease that you get with CKD, and it contributes significantly to the cardiovascular morbidity and mortality. It causes alterations in the calcium and phosphate hemostasis that affects bone turnover and mineralization, along with progressive vascular and soft tissue calcification. So clinically significant changes are not generally that obvious until about stage G4 of chronic kidney disease. So as a general rule, the calcium phosphate, parathyroid hormone, and vitamin D monitoring is not necessary in lower grades of the CKD, so grades 1 to G1 to G3, but it becomes necessary in patients with more advanced CKD in G4 and G5. But usually these patients are under the supervision, certainly in the UK, of a nephrologist. But obviously if you don't have a nephrologist available and you're the one managing your patient, you'll need to be mindful of this and think about checking it if you have the facilities to do so.
So the management normally involves dietary and pharmaceutical approaches to phosphate, vitamin D, and parathyroid hormone serum levels. So hyperphosphatemia can be controlled with a low phosphate diet, but if that doesn't work, then you can get binders that you take with meals. You may need to replace vitamin D, so supplement that in patients with stage 4 to 5 CKD, and 1-alpha hydroxylated preparations are normally used. And again, to be honest, this is something that a nephrologist is telling me what to do, because it is, these patients are complicated. And if I'm honest, if I get a phosphate level back that I don't understand, I'm just asking for help, because it is, it's complicated medicine.
Yeah. So as I mentioned before, Fran, there's this KDIGO or KIDIGO, the Kidney Disease Improving Global Outcomes Guideline, which is available, and it's an amazing document, and you can adapt it for use based on your local availability of phosphate binders, vitamin D and its analogues, etc. And it doesn't just cover the mineral bone disease, but it covers all aspects of chronic kidney disease. And we have attached it as a separate PDF within the course, so you can just click on the link here if you want to look at it, or you can open the attached PDF in the section below and then download it and refer back to it as you need to.
That's fantastic. Yeah, great stuff. And so, we mentioned there asking your nephrologist if one is available to you. So, if we think a little bit about when would we refer to them, and when would renal replacement therapy start? When do we time that? So typically patients require specialist referral if they're in this GFR category of G4 or 5, which you were mentioning before, weren't you, Minnie? If they have an ACR of more than 70 milligrams per millimole, unless it's due to diabetes and it's already being treated. If they have an ACR of more than 30 milligrams per millimole, so that's A3 with hematuria. If they have a sustained decrease of 15% in 1 year, or a decrease of GFR of more than 25% and a change in CKD category. That's quite complicated to think about that.
It is, isn't it?
If they're hypertensive despite 4 antihypertensive drugs, if they have a known or suspected rare or genetic cause of CKD, or if you suspect renal artery stenosis.
Okay, so the nephrologist's role here is in managing patients with CKD. It's also to identify those who may require renal replacement therapy, the RRT. So they provide additional input into managing difficult complications of CKD. For example, as you mentioned, Fran, these patients with uncontrolled hypertension despite maximal 4 antihypertensive, or giving you advice on these rare or genetic causes of CKD. And they're usually able to provide specialist tests such as renal magnetic resonance angiography for suspected renal artery stenosis. But, these are highly specialized tests, expensive, and they may only be 1 or 2 areas able to provide that in your locality.
So we know that early referral affords the opportunity to discuss management options. So if you're thinking about renal replacement therapy, so that's dialysis or transplantation, refer early so that the nephrologist can discuss all the options with the patient, and if needs be, they can establish vascular or peritoneal access for dialysis, enable the use of appropriate treatment for uremic complications. So do you remember, we talked, didn't we, about how chronic uremia may be linked to the increase in malignancies. So, that's really important, that can be treated, and it can reduce mortality. And conversely, a late referral to a nephrologist, so that's looking at, less than 1 to 6 months before the initiation of dialysis therapies. So, this is the crash landing that we mentioned, didn't we, in part 1, when these patients are being, probably presenting late and then being referred late. We know that that's associated with an increased mortality and poor median survival rates, and probably due to these patients presenting with worse biochemical and nutritional profiles because they've become so unwell.
Another thing to think about is that if a patient has features of a post-renal obstruction or a malignancy, that you also need to be referring them to a urologist, not just to a nephrologist. So adults over the age of 50 years who have persistent microscopic hematuria should undergo prompt investigation for malignancy by a urologist. So that's quite a helpful little tip as well.
And then thinking about acute kidney injury, so I mentioned this with one of my patients. So patients who have had acute kidney injury are at higher risk of developing CKDs. I have a patient who springs to mind who was on ITU for some time with a chest infection, was very, very poorly and went into acute kidney injury. And in fact, she has developed CKD and high blood pressure. I'm not sure whether the high blood pressure was there initially or whether it has now been caused by the CKD. It's that chicken and egg cycle. Yeah. These patients, so anyone who's had an acute kidney injury, should be monitored regularly for chronic kidney disease for 2 to 3 years afterwards, even if the EGFR in that time returns to baseline. Just keep monitoring, just, be suspicious in these patients that it might go wrong again.
Okay. So obviously it's important that once you've established someone has CKD, that you continue to monitor them. And this involves regular monitoring of their EGFR and looking out for its decline and new onset or worsening albuminuria. Of equal importance is the monitoring of their underlying diseases, which we've mentioned. So, for example, their diabetes, their systemic hypertension, their HIV, and looking with vigilance for complications associated with worsening CKD stages, such as anemia or hyperphosphatemia and hyperkalemia. So looking at NICE as a way of looking at some guidelines, they advise tailoring monitoring to your patient and their wishes, the speed of progression of disease and the severity of the CKD. So what does that mean? For those patients with G1, G2 and G3A, A1 to A2, annual monitoring, so that's once a year monitoring, is adequate. For patients who have a slightly worse CKD, so G3A, A3, G3B and G4, A1 to A2 require twice yearly monitoring, and G4, A3 and beyond, so the more severe end of the spectrum, these patients need much more frequent monitoring. So these patients are likely to be under the supervision of a nephrologist, but if they're not, then you'll need to be doing this monitoring. And remember that if changes occur to their medications or they have comorbidities or intercurrent illness, then again, you'll have to increase the frequency of your monitoring.
Yeah, that's really important, isn't it? Particularly that intercurrent illness, looking at maybe stopping some medicines when you're unwell because you'll become more dehydrated, say, if you have a feverish illness. And Minnie, there will be some patients in which conservative care is the most important thing to do. So these are patients who have got, worsening kidneys, that they're heading towards kidney failure. And so you may be talking about dialysis or transplantation, or you may be saying, let's treat this conservatively. Conservative kidney management, it's a sort of emerging subspecialty within nephrology. And that involves talking with the patient, and in some cases, patients won't want treatment and they will just want palliation. Now, sometimes this means not starting treatment, and sometimes it involves stopping it. So maybe stopping dialysis or not starting dialysis. And I talked earlier about this sort of holistic approach, so looking at the whole person, and that involves, managing their symptoms, which may be physical, so it might be pain or itch is a really common one as the urea level increases. Their psychological symptoms, spiritual. It really requires really good communication, not just with the patient, but with the family and all the doctors. And really good team work, doesn't it? So it's, the nephrologist, the palliative care doctor, if you have one of those available, the primary care clinician, be that a doctor or a clinical officer or a nurse, possibly even a religious figure, and then, maybe using end-of-life care support. So if you have hospices available, it may be that you're using them as well. And I was telling you earlier, wasn't I, Minnie, about a patient of mine who was on dialysis and stopped attending, and he would just refuse to go for weeks and weeks, and then he would go again, and unfortunately his access had stopped working, so he had a vascular access and it was no longer working. And eventually the nephrologist got a psychologist involved because it was a very complicated situation. He was quite aggressive to people if they went round to his house to try and take him to dialysis. He would set his dogs on people. He didn't really seem to understand what was going on. And the psychologist spent a lot of time and actually discovered that, as well as obviously the chronic kidney failure, that he also had some dementia and wasn't really capable of making good decisions. And it was very, very difficult trying to manage him well. And it was just out after really long, heartfelt discussions mostly with his family and with him as much as he could understand, and with the nephrologist and with me, that, letting him go home, giving him this palliative care support, managing all his symptoms, and letting him die with some dignity in his own home, which is what he wanted, was the best thing. And actually it was really positive in the end, because it had been quite fraught beforehand.
Yeah. Oh, thank you for sharing that with us, Fran. That's really helpful.
You're welcome.
So if we just think about our patient Marge, I mean, we haven't discussed her yet this module, but we did talk about her in part 1. So we'll just return to her and see what advice was given, as we found she had some chronic kidney disease. So she was referred for a smoking cessation counselling and given advice on weight reduction. She was told to stop taking her non-steroidal anti-inflammatory drugs and use paracetamol or heat instead for her arthritis. And her antihypertensive medications were increased, and she was also given an ACE inhibitor, aiming for a blood pressure of less than 130 over 80. Because she'd had a rapid decline in her renal function, she was also referred to a nephrologist, and they worked with her GP to optimize her blood pressure and reduce the proteinuria, as well as giving her IV iron, as she was anemic, if you remember from her blood results. So she was monitored, and over the next year, her renal function stabilized, and she has carried on being reviewed on a regular basis.
Oh, that's great news, isn't it? So, really managed to help prevent her chronic kidney disease from just spiraling downhill just by, some good treatment.
Yeah.
So, Minnie, should we talk about prognosis? Because let's see what happens to these patients. So, a UK retrospective longitudinal cohort study, that is a mouthful, looking at data from more than 400 primary care practices in 2010, found that the prevalence of CKD stages 3 to 5 was 5.9%. So of these people, disease progressed by one CKD stage, so it worsened by one CKD stage in about 10 to 15% of these patients. It remained stable in about 50%, so that's good news. And it improved, which is fabulous, in about 25 to 30% of patients. So that was really positive.
Yeah. So this study also found, Fran, that people who had an accelerated progression of CKD had an increased risk of end-stage renal disease. And over a 5-year period, less than 2% of people with CKD will progress to need renal replacement therapy. So that's dialysis or the kidney transplantation.
So it's interesting, isn't it? So, and we've mentioned this before, that people with CKD are 5 to 10 times more likely to die from other causes than to progress to end-stage renal disease. So I think what I found when I've told patients that they have chronic kidney disease is that the biggest fear is they're going to end up on dialysis or transplantation. But the reality is that that's really unlikely. What have you said there, Minnie? 2% are going to end up with that. But actually, the risk is that your mortality risk is rising as your CKD disease progressions, and it's mostly from cardiovascular disease, from diabetes and hypertension.
Yeah, I thought I would like to add some additional information to CKD because things have been changing quite quickly. So firstly, looking at primary care, there are now additional medicines that we can start on our patients in primary care, and obviously this will depend if they are available to you in your setting or not. So the first thing that we should consider, and we talked about the risk of cardiovascular disease in our patients with CKD and about starting a statin. Well, now the current guidance is also that we should offer an antiplatelet to people with CKD for secondary prevention of cardiovascular disease. Now, in my setting, this would be aspirin 75 milligrams. You may have a local equivalent that you would use. The other drug that we should also be considering offering is a sodium glucose cotransporter 2, or an SLGT2 inhibitor, if appropriate, and again, if available. So these are relatively new drugs. We've been using them a lot in diabetes recently, and now they've been extended to be used in patients with CKD. So the two examples are empagliflozin or dapagliflozin, and these are options as an add-on to optimized standard care, which would, as we talked about, include the highest tolerated licensed dose of an ACE inhibitor or an ARB, obviously unless they're contraindicated. And that is in people with either an eGFR of 20 to 45 mils per minute per 1.73 meters squared, or an eGFR of 45 to 90 with either a raised ACR of 22.6 or more, or type 2 diabetes. So those are the groups of people that we're going to be using them. In people with type 2 diabetes, you're going to be considering offering an SLGT2 in those patients who've got type 2 diabetes and CKD who are on their optimum dose of their ACE, and if their ACR is over 30 and they meet the eGFR thresholds. Now, this is not a topic on diabetes, but in my experience at the moment in the UK, certainly, pretty much all our patients are now on an SGLT2 inhibitor because we know that they're very good for lowering sugar levels and they also reduce cardiovascular disease. So we try and get all of our patients taking them. So what are these drugs? As I mentioned, they're dapagliflozin and empagliflozin, and I've put links there to the British National Formulary, which will tell you a little bit more about both of them. And they do have some side effects. Common side effects are fungal genital infections, and you typically get this because one of the ways they work is by reducing your sugar, and they do that by getting you to excrete excess sugar in your urine, and so that makes your urine very sugary, and that increases the risks of infections around your genitals. You also have to take a lot more care with your feet, and if you develop feet ulcers, you need to be stopping this medicine, and also you need to take care with not becoming dehydrated. So those are relatively common side effects. And then there are two rare but potentially life-threatening side effects, and one of those is diabetic ketoacidosis, and this can occur somewhat sneakily in patients whose sugars aren't very high. So you can be misled by that because DKA, as we've all been taught, typically presents with people with very, very high sugars, but not on these patients on this empagliflozin or dapagliflozin. So you need to be warning your patients of those symptoms. And also there's an incredibly rare disorder. I've only heard of a patient once ever having it. It's something called Fournier's gangrene, which is a very destructive infection of the genital area. We do need to be informing our patients all of this. Lots of places have leaflets that they give patients. I've just attached an example one from a teaching hospital in the UK. And then finally, there is a new drug which I haven't been prescribing in primary care called finerenone. It can be started in secondary care at the moment. I imagine it will move to primary care in the UK at some point, and that is as an add-on therapy for some people with type 2 diabetes who are already on an ACE or an ARB and an SGLT2 inhibitor. And again, I've put a link on for you there. What other updates? Well, vaccines. So we need to make sure that the person is offered immunisations. So influenza annually, we would be offering them in the UK, and also for pneumococcal disease to reduce infection risk, possibly for COVID as well, depending on your local vaccination schedule. I think one thing that we didn't necessarily talk about was about communication, and it's really important to give adults with CKD and their family or carers information about their risk of needing renal replacement therapy. And certainly I've had conversations with patients where I've been very careful about how I've phrased the name of their illness, and even then they've come back to me several months later saying, I have renal failure. And I've said, no, that is absolutely not what I said. So, the words are not brilliant. Chronic kidney disease sounds terrifying, so our communication is really important. We need to be using everyday language, jargon-free, to talk about their risk and, to explain to them the chance of them ever needing dialysis, ever needing a transplant, and obviously give the patient time during the consultation to ask questions and to arrange an appointment if they want more discussion. And then finally, we talked about referral earlier on in our part 2, but just a couple of new considerations that I thought might be useful. Instead of just using a more blanket decline in eGFR, which sometimes is I find as a clinician a little bit confusing to be calculating. There is something that we use in the UK called a kidney failure risk equation. And this gives a 5-year risk of needing renal replacement therapy. The guidance is if that is greater than 5% over 5 years, then for me, I need to be referring to a nephrologist, a kidney expert. Now, this equation has been validated on thousands of patients in more than 35 countries, but the link that I have sent you is specifically validated for UK primary care. So, please feel free to use it, but do please take that into equation when you're thinking about how to treat your patients. I've put a link on the transcript and there is an infographic of what it looks like. But for me, I found this incredibly helpful to know when I should be referring and when I shouldn't. Other things that might get us to refer, and again, we talked about these before, a decline in nutritional status or malnutrition or persistent high potassium. So we may need specialist dietary advice about potassium, phosphate, calorie intake, salt intake, renal anemia if the patient needs EPO or IV iron, renal mineral and bone disorder, because again, we may be needing to use more specialized medicines such as phosphate binders or persistent metabolic acidosis. And of course, if there's any sort of diagnostic uncertainty, we would be referring then.
So that's quite a whistle-stop tour through chronic kidney disease. Do let us know if there are other aspects of kidney disease that you would like to hear about.
And if any new things come along, we will update then as well. Thank you all so much for listening. I hope you enjoyed the course.
And remember, you can download the supporting notes, complete the CPD quiz and receive your certificate at www.horizonmedicaleducation.com. If you found this episode useful, please share it with your colleagues and follow us for weekly episodes. Goodbye.